signs, symptoms of the acute iridocyclitis. How will you diagnose a case of acute iridocyclitis? Because signs means whatever we examine under the slit lamp like that. Symptoms as the redness and the pain, irritation, photophobia that patient can complain. But the important thing is the signs which we are seeing after examination. That is the important part. That you have to write that. So inflammation of the iris in the ciliary body is iridocyclitis. Iris plus cyclitis, inflammation of both iris and the cyclitis part. Symptoms of the pain, redness, photophobia, blepharospasm, lacrimation, defective vision also. These are usually the uveitis as well as the ulcer are the common symptoms of pain, redness, and that. Something about the redness. Redness is which type of the redness is in acute iridocyclitis? If you heard about, what type of the congestion is there? Clinically, that is important. When we are talking about the redness or the congestion of the conjunctival congestion, we should know that in the conjunctiva we have discussed about it. Two types of the congestion. One is the superficial, another is the circumcorneal or the deep congestion. Superficial in the conjunctivitis, if someone is seeing noradrenaline, they will blanching, there is direction of this one or the arborizing phase. One is the more in the furnace phase, another is the circumcorneal or the around the corner. That we have to diagnose. So circumcorneal or the deep congestion is very, very important in uveitis part. That is the redness or the circumcorneal congestion will be finding that in acute iridocyclitis case. Then we are coming to the signs, important one. Lid edema. Because this is the inflammatory condition, it can be infective or it can be mostly this is the allergic nature. Ciliary congestion we have discussed about. And there are certain structures we have to explain whenever we are discussing the signs of the sign. What are the signs important? Many times in the examination I ask what will be the findings in cornea in case of acute iridocyclitis, or signs of iris, or signs of this in the antechamber or in the pupillary case. So we have to examine separately and we have to remember this separately, we have to write separately also. Clinical diagnosis, clear cut signs. When we are discussing about the signs in the cornea, see that corneal edema will be one. KPs, what are the KPs? Usually KPs are proteinous cellular deposits. Proteinous cellular deposits. So cellular deposit cell comes from the vessel because the permeability after the infection that change. So cellular that comes in the neutrophil or the lymphocyte, the plasma cell or the plasma or proteins comes out in the iris and comes in the antechamber. Whenever they are suspended in the antechamber, the aqueous, that is called self. One is the self, another is the KPs. So KPs, whenever they are deposited over the posterior side of the cornea, that is called KP. Here you can see that is the posterior surface of the cornea, endothelium. These are called the KP, mostly in the lower part of the cornea. These are the types, mutton fat and medium size and all the fine KPs on this. This is behind the cornea. The important signs of the uveitis, acute uveitis in the cornea is the presence of KPs. So these are the proteinous cellular deposits at the back of the cornea. They can be mutton fat KP, small and the medium KP, red KP, the old KP. These are the varieties of, and the posterior corneal opacity. So corneal edema, KP and the posterior corneal opacity, these are the important findings of acute uveitis in the cornea. Coming to the antechamber. Antechamber will be two things. One is cells, because the cells they are permittively changed, they are coming in the extra. So normally up to the 6 cells, with neutrophil, plasma cells, fine cells, if they are suspended, these are the normal cells. Whenever more in that, then we classify them 1 plus, 2 plus, 3 plus. So we write that the cells are present and the 1 plus and the 2 plus. That we divide 11 to 20, the 2 plus, and the more than 21 to 3 plus, and the over 50, the 4. We can count them under the slit lamp also. These are the cells. We are from where they are coming? From the iris vessels they are liberating from. Cells and proteinous material also. Then the flare. What is the flare? Flare is the proteinous material which are suspended there. This is Tyndall's effect, that the turbidity that causes in the aqueous. So important finding in the this iridocyclitis is the KPs first, cells, and the aqueous flare. Depending upon the density, when the iris or posterior structures are seen, all the posterior structures are clear cut, then we are dividing 1 plus, 2 plus, or 3 plus. Or 3 plus, we cannot see the posterior structure because turbidity is so much, we cannot identify the posterior structure. That is the aqueous flare. So the aqueous flare, KPs, and the cells. Now many times we are asking, what is aqueous flare? So aqueous flare is the proteinous material. They are suspended in the anterior chamber, which causes the turbidity of the aqua. From where it comes? From the same capillary here, the capillary blood vessel they are liberating. So that is dependent upon the so cells we can grade them, and this one, the flare also we can do. How we are grading? Depending upon the posterior side, posterior structure, if we are able to see or not. That is the previous grading of this. Then the other finding in the anterior chamber will be hypopion. What is hypopion? When they were pus cells and all these cells suspended in the lower part of the angle, that is hypopion. Hyphema is the blood whenever they are coming. Because why I am telling you? Because we are having a slide just showing the picture. One slide is having the hypopion, one slide is having the hyphema. So you have to identify. In the short case, we can give you what is this. Diagnose this structure. You will tell hypopion. What is hypopion? What are the causes of the hypopion? How will you treat the hypopion? If you say the hyphema, hyphema is what? What are the causes? How will you treat that? What are the complications? So that these things are important. First you identify, then the causes with diagnosis. Then the other finding in the antechamber is the change in the depth and shape and changes in the angle of the antechamber. These are the some changes in the antechamber. Then coming to the anterior, we see iris part. These are the findings of the loss of pattern because there will be edema, fluid will be there, loss of pattern is brownish or the muddy iris will be there, and pupil will be myose, the narrow angle pupil because the fluid that gives pushing the iris part to the center side, so that myopia, projection of the pupil occurs. Changes in the color, normally it is a brownish, then becomes muddy in the acute iridocyclitis. Iris nodules, there are copies on the border and the basaka needle. Posterior synechias also. Segmental, annular, or the total posterior synechia, and the neovascularization. So these are the iris findings in acute iridocyclitis. One is the loss of pattern, color changes, iris nodule if found in posterior synechia, or the neovascularization. Just see that this is structure. Typical. Upper picture showing the nodules. One is in the iris part stroma. This is basaka nodule. This is found in syphilis or the tuberculosis of that part. Or if the nodules are at the border, these are the nodules at the border. These are copies nodules. That is mostly in the sarcoidosis. So these are the nodules, copies nodules, and this basaka nodules. Then there are segmental diseases. This is the iris, this is attached at the center, this is annular synechia. This is the total synechia, whole of the iris is attached to the anterior surface of the lens. If this is the annular synechia, means border is synechia all the around, it causes the seclusive pupil. It pushing from the anterior side, this is aqueous, pushing the anterior side, this is the anterior side. This condition is called iris bombing. Here the center part is the deeper and the lateral part is the shallower part. This happens in the acute iridocyclitis, while whole of the margins is attached, or this is annular synechia. This is called seclusive pupil. What is occlusive pupillae? Is the whole of the pupil is occlusive with the occlusate. So these are the findings in the iris nodules and this part. Nodules and synechia, segmental, annular, the total, and the neovascularization. Neovascularization, you know what happens? Where it occurs? The diabetes or central retinal vein occlusion or like that. Causes the neovascular glaucoma. These are the findings in the iris part. Pupillary signs, narrow pupil because we fluid collection and we pushing that. Irregular pupil, especially when you dilate, there is a synechia, dilate the pupil. the pupil becomes irregular after that because some part is dilated, another is the constricted part. This is called festoon shaped pupil. This is the shape. Here this is synechia, the attach. Here this is the dilation part. Here again synechia. This is festoon shaped pupil. Because this is the slide we are keeping with us. We are showing you what is this. You can say this is, sir, this is a festoon shaped pupil. Why festoon shaped pupil? Because somewhere this is attached, synechias are there, somewhere the pupil is dilated, this is irregular pupil. Then the question, where it is found? Sir, this is in acute iridocyclitis, irregular pupil, somewhere synechia like narrowing part of this one. These are the iris signs. You should not forget this. Then there are changes in the lens also. Pigment dispersal, because the iris pigment they are attached to the lens. The pigment exudate. They are two cells. They are coming in the pupillary on that. Complicated cataract, secondary cataract, that is called the typical shape, features polychromatic luster and the brad crumb appearance. This is the secondary cataract or the complicated cataract. It starts from the posterior subcapsular side because the metabolism is disturbed. This is called the secondary cataract or the complicated cataract. Typical features the polychromatic luster or the brad crumb appearance, so that we can diagnose that. This is the secondary cataract. Changes in the vitreous, this is exudation in the inflammatory cell, that is in the pars plana side. So these are the findings in the lens you can find. Then we are coming to the posterior side, the complications. Suppose this is the changes in the vitreous and the pars planatis, then the infection of the uveitis can go posteriorly, posterior uveitis. Then the other side, or pan uveitis. Complicated cataract. What are the complications? Because many times the question comes, enumerate all complications of the iridocyclitis. Now, how will you treat them? How will you manage them? That is also a separate question. Serial wise, that is sequence wise, these are the complications are occurring. I'll tell you how these things develop. Complicated cataract, which we have seen that polychromatic luster or the brad crumb appears in the posterior subcapsular part. Why it occurs? Because whenever there is inflammation, other signs, aqueous flares, the capes are there. Posterior side is also involved, so that disturbs the metabolism of the lens. So some corneal opacity, the lenticular opacity develop posterior subcapsular side. This is the brad crumb appearance of the secondary cataract. If that remains for a longer period or the not treated, this is one complication. Secondary glaucoma. Why I am telling this is secondary glaucoma? Because the primary glaucoma is a separate one, is a primary cause. Secondary glaucoma is the disease is one. Later on, it causes the glaucoma. So this is called the secondary glaucoma. We have divided this glaucoma in uveitis into two parts, early part and the late part. Early is whenever the all cells and the flares and these are occurring, they are clogging the trabecular meshwork, and some trabeculitis is also there. That causes the drainage hamper, obstruction of the drainage, causing the glaucoma. That is called early glaucoma. This is one. Because of the cells, because of the changes in the trabecular meshwork, clogging that cells and late glaucoma. What is it? Whenever there is all synechia or more than 2/3 synechia of the iris, that is because the drainage, the posterior to anterior side, is disturbed. That causes the pushing iris, the bombi or other part, occlusive or occlusive pupillae, that causing the changes in the pressure, raised pressure. This is called the late glaucoma. So there are two types of the two phases of the glaucoma, early glaucoma and the late glaucoma. That is the correct. Cause of early is the cells and the aqueous flare, the proteinous material, and some trabeculitis and the toxic material. And the late is due to the synechia, so that there will be no drainage of it. Then comes the cyclitic membrane. What is the cyclitic membrane? Because of the deposition of the all inflammation, that in ciliary body there is a membrane like a structure is formed posteriorly. That is called cyclitic membrane or the plastic membrane. Plastic iridocyclitis, that the name is given. Posterior side of the ciliary body. That is also a complication before behind that. Choroiditis. What is choroiditis? Some infection goes pars planitis and up to the choroid, because choroid is also a part of the uveal tissue. Some inflammation of that causes the choroiditis. Usually in the sympathetic ophthalmitis that is occurring. That is a sequence wise when the choroid is involved, that is choroiditis is also. Retinal complications comes the CME, systemic cystoid macular edema, macular degeneration, exudative detachment with solid detachment, and the secondary periphlebitis. These are the changes in the retina. Cystoid macular edema, optic neuritis, and the papillitis, and the exudative detachment, periphlebitis, or the macular degeneration. Many times the hole can be found also. These are the changes in the retina found. Papillitis. Papillitis is a part of neuroretinitis or the optic neuritis. This is the inflammation of the disc become blurred of this on posterior side. That is also a complication of the optic disc in the papillitis. Band-shaped keratopathy. Band-shaped in the calcium deposition, the area of the calcium deposition in the palpable part of the cornea. That is all. The long-extending chronic uveitis and phthisis bulbi. Do you know what is phthisis bulbi? Shrinkage of the eye, total atrophic eye, that's called. So why it happens? Because of the inflammation of all these things, ciliary body is involved, and many after that the ciliary atrophy occurs. Whenever the ciliary atrophy occurs, ciliary body stops secretion of the aqueous. Slowly and slowly it becomes atrophic and it becomes small in shape. We cannot identify the structure. That is called the phthisis bulbi. Having three stages: early the atrophic stage, then the phthisis bulbi without disorganization, and with disorganization, separate shortener becomes that, because the slowly and slowly disorganization means we cannot identify the structure. Iris we cannot see, antechamber we cannot see that, or all the rectangular shape the eye becomes that. That is disorganization. That is called the phthisis bulbi. This is the last stage of it. So just to enumerate the causes of this one again: complicated cataract, one is serious. Have this all things occurring there slowly and slowly there. Cyclitic membrane, the inflammation posterior side, choroiditis posterior side, retina involvement, papillitis, band-shaped keratopathy, and phthisis bulbi, and the glaucoma also. You know, whenever there is inflammation of the iris in the ciliary body, just we see a serial wise. Whenever there is a infection or the inflammation of the iris part, there will be permeability changes in the inflammation. Cells comes in the iris part. First, lymphocytes, erythrocytes, or whatever the cells come, then the iris becomes muddy, and that pupil it becomes myoid. Then it comes in the antechamber, then the flare comes, capes come, and the aqueous cells come. They are depositing in the cells. Hyphema, the aqueous. If this is not treated there, when the pupil is narrowed part, when the proteinous material is there, posterior side of the iris and in front of the lens, proteinous material, because that is a rough surface, and it remains for a longer period, this proteinous material, there is fibrin deposition that contracts, so there is a synecdoche formation deposition. Initially it is segmental, then annular, or the total synechia occurs. So whenever the synechia plus that exudates all becomes in front of the pupil, that is called exudative or the exudative disc. Synechia part of this one, total synechia. So seclusive pupillae and the occlusive pupillae and the all exudates come in front of it. Whenever this exudates and everything comes out, then the pressure increases. That is the late glaucoma. Late glaucoma. Whenever the all process going on posterior side the ciliary body, there is a plastic iridocyclitis or the plastic iridocyclitis. Then posterior side is a pars planitis or the vitritis. Then the choroiditis, retina, and every part. We slowly and slowly, first it involves the anterior side, then the posterior side, then the retina and the macula and these parts. And lastly, when the eye becomes atrophic, that is called the phthisis bulbi. So these are the six sequence-wise complications of the iridocyclitis. So we have seen the anatomy of the iris, ciliary body, and the choroid part. How we classify the iridocyclitis? There are different classifications: anterior, posterior, suppurative, non-suppurative, and granulomatous, non-granulomatous. Then there are signs in the other, in the aqueous layers on the other part, cells and the synapse and the corneal part and the important part, these things. And the lastly, the complications of the iridocyclitis. If the question comes, enumerate the complications, these are the how will you treat that part complication? Later on management, if you are when the complicated cataract, treat like a complication cataract like remove that lens and implant the secondary glaucoma, we can treat that. Later on the surgery like choroiditis and the retinal complication, all these things can be initiated, treated like. So that finishes your today's first part of the signs, symptoms, and the anatomy and complication of this. The next time I will be taking the all investigation, differential diagnosis, and the treatment of this uveitis part. Then we will start the another topic of this. To go through this topic, anatomy and everything, science of this one, what are the complications, the sequence wise, what happens, what is the occlusive pupillae, what is occlusive pupillae, what is the exudative membrane, what is the plastic membrane, what is the pars planitis, and all these things to go through that.